Welcome to the 2024 I Reclaim Summit. Let's give a big round of applause for that. Listen, I am so excited to be your host. For those that were not here yesterday, my name is Frank Grimsley, also known as Frank in the City, and so I'm going to be talking to y'all. I am not your host. I am your friend. So just look at me as your friend guiding you through this conference, okay? Is that cool? All right, so we're going to kick things off, and the first up is we have a renowned HS specialist coming to speak to us. We have Dr. Iltefat Hamzavi. He's a Detroit-based dermatologist, researcher, and activist with over 200 peer-reviewed publications. He is the founding board chair member of Emeritus of ISPU, past president of the Hidradenitis Suppurativa Foundation, and a managing partner at Hamzavi Dermatology. Dr. Hamzavi is also a leader in village research and advocacy. Give a round of applause for Dr. Hamzavi.
You got all those terms right. And you got my name. Jasmine, nothing but the best for you. Welcome to Detroit. I am so grateful that you are in my hometown, but really this is Jasmine's hometown. This is the place that raised her, and still we consider to be the birthplace of the Jasmine mystique. Now, what is Jasmine mystique? It's the color purple inside of the HS logo. It's the beautiful colors that's laid out perfectly in this wonderful stage. It's color that bursts through darkness. And working with this young lady for so many years, if she calls, I just gotta show up. And I'm not the most organized guy. My good friend Brent is from the HS Foundation is with me, and I work with him for many years. And I was lucky enough to watch people like Jasmine come through my life, and I'm not supposed to be here right now. I'm supposed to be in Chicago. But somehow, when the sun calls, the moon just shows up. And so, Jasmine, I wanted to thank you for organizing this meeting. I want to thank all of you for being here. I want to thank all the partners for supporting this work. But mostly, I want to thank the patients and their caregivers. Our clinic is right across the street. The HS Foundation, much of the initial work started off over there. But the HS clinic at Henry Ford has been there for almost 15 years. And it's a place of hope. It's a place, as our MC suggested, of gratitude. It's also a place that doesn't hide from some of the challenges that we're facing with HS. So today, what I like to do is talk to you about some of the upcoming advances in HS. But we're going to do this together. I can give you a massively boring scientific presentation. I don't think it's boring. I think it's awesome. But you might find it a little boring. So you got to kind of give me some insight on what you want to hear. And so this is a scientific presentation that's geared for a grand rounds audience at a major academic medical center. But it's also driven with passion and integrity and honesty for the care of our patients. So as we go through this presentation, if you think that this isn't exactly what you want to hear, let me know. You can throw tomatoes, you can make fun of my outfit. Just don't make fun of the Detroit Lions or the Detroit Pistons, especially the Detroit Pistons. They have a facility right here. I know they have the worst record in the NBA ever, but there's always hope. So this is our hometown of Detroit. Oh, wait, you guys, you can't see the slides, can you? Oh, okay, wow. Did you go to film school or something? Oh, yeah, you did. So this is Detroit, our beautiful town. It's a resilient place. We have the new Gordie Howe Bridge going up. We have the Michigan Train Depot. We also have, I think, probably the largest HS clinic in the country. It's a place that shares everything that we have. Dr. Colleen Cotton's here. She spent time with us, and many members of the HS Foundation have spent time with us. But it's a place where we embrace everybody. We're also authentic, and we can be kind and generous, but if you are going to do something that's not right with our people, we can be downright mean. I have to state there's a conflict of interest, and Dr. Cotton and Brent and I were talking a few minutes ago. Sometimes I'm challenged by the amount of industry funding that comes into our space. But I'm also not going to hide that because they have been the best partners for us. They're funding part of this meeting, but the HS clinic started before there was any industry money. There were bake sales, there was Henry Ford Hospital, there was our Department of Dermatology, there was the Hamzavi Foundation, there was a few local groups funding the work here. And then pharma got on board, and they really helped bring awareness. There's also a conflict of interest in which we have to be aware of how pharma is making their money. But I don't want to discount the knowledge that comes out of this. And I want you to push back if you feel that that knowledge is conflicted, but I also want to explain to you what advances are going to happen that can help you. There's also going to be a huge conflict of interest in that many of these medications are incredibly expensive. And we have to find a way to make them accessible to all populations. And being from Detroit, we know how to fight. So we're going to work with pharma partners. We appreciate you being here. And we're going to work with our payer groups. We're also going to do the research to show which ones work. But when you see these conflicts of interest, they do mean something. You should hold us accountable, but they also mean that treatments are coming. The more conflicts of interest, in some ways, the better it is, as long as there's somebody watching over the farm, because there's a lot of foxes taking money out of the farm. We got to make sure we grow better sources of treatments. So what I'm hoping to do is kind of give you a view of how we view HS today and how it's evolving. And I'm going to kind of first off talk about HS and how to tell the story. And I'm not going to talk about this, but I want to talk about this first. Every presentation I give to any academic center, I always start off with Jasmine's incredible documentary. If you go on YouTube, you can find it. I'm not going to show the video. Jasmine can talk about it. But one of the things in American English is how the skin is dismissed. And Jasmine's story, in which in this particular scene, she's actually having a collegiate or graduate school event. She can't go to the event because she's having some discharge and bleeding and some pain from her skin lesions. But the emotions she conveys, I could do 50 quality of life studies, and I could never convey it. Now, many of you in this audience already know this. But one of the things that we have to do as a community is to tell people how devastating this disease is without taking away hope. There's going to be lots of hope. But when you advocate for this disease, part of the advocacy has to be to tell the story. And one of the things that we try to do is describe what HS is. As you know, a couple of years ago, we did some studies, and it took on average 7 years for somebody to be diagnosed. If you just put into Google, I keep getting boils in my underarms, the first thing that comes up is Hidradenitis Suppurativa. So why does it take so long? So we've been trying to do education. The HS Foundation has been a leader in doing this. But this JAMA article, which talks about how you diagnose it, that's been a simple advance. We also have an incredible research team at Henry Ford. Dr. Shishing Mi, he's a NIH-funded researcher, does a lot of immunology. Dr. Richard Huggins, my clinical partner. We see a lot of patients at Henry Ford, and we have to make a lot of decisions. And he is just a worker. And if you ever see him, I hope you say thanks. He also does vitiligo, another disease state, but always passionate, always caring. Now, this is our population at Henry Ford Hospital. You can see the rapid increase in the number of patients over the past couple of years. The fact that people are now more aware of HS is a factor. The fact that pharmaceutical companies are advertising and creating awareness, but also a lot of that is a social media influence because people have a basic understanding of what HS is. But one of the challenges is that there's not enough centers developing. Now the HS Foundation has a center list of all the centers of excellence, but one of the things that we're going to face is that HS is actually much more common than we ever thought it was. When we started our clinic, they told us that it was 0.1% of the population. If that's the case, then I should only have to do HS clinics every 3 months. And then it became every 2 months, then every month, then every week. Now, almost half my patients that I see in my clinic have HS, and that reflects that graph. The other discovery that's been coming up in updates is that HS, in many ways, is inflammation of the skin that's associated with a lot of other autoimmune diseases. And that's a list I'll be talking about again in a few minutes. So the two questions to ask if you're trying to make HS diagnoses are those two questions. And that's, I believe, an advance in research. Those two questions can be asked on a questionnaire, and social media is a great way to target people's accounts in a good and bad way, but also to ask them, how commonly do you see this? And this advance has led to a questionnaire that will give us a better idea of how common HS is. Why is that important? Because if you have a better idea of what the numbers are, payer groups, governments, pharmaceutical companies can see the impact of this condition on different people. So those two questions have been in advance. And then we're doing a better job of describing what HS is. And how many of you know the Hurley staging? Okay, very familiar group. So if you don't know Hurley staging, a nodule is basically Hurley stage 1. When you have a sinus tunnel, Hurley stage 2, and then Hurley stage 3 is when there's no normal skin in between. One of the big advances that's happened over the past couple of years is understanding that when you have a sinus tunnel, you really need to do procedures. You have to remove that sinus tunnel with de-roofing, which we'll talk about, as well as other excisional techniques like CO2 laser or elements like that. And so that has kind of helped us develop a paradigm where we're taking the statistics and we're also taking the understanding of the disease state and describing this. So the epidemiology. HS, we think today, is about 1 to 4% of the American population. And I think most clinics feel that way. The reason why we think that the numbers were so much lower as before is because people weren't coming to physicians or nurses or PAs for care. It tends to be more female in the United States. And we're going to talk a little bit about that, but there seems to be a role of hormones that drives the immune system in HS. There seems to be a higher prevalence in Black Americans. In our population, about 49% of our population at the Henry Ford system is Black American. Our city is 85% Black. Our region is about 20% Black. So it's disproportionately even for our region. But in every study nationally, it's about a third of the population ends up being Black American. And then there's a massive increase in adolescence. Dr. Cotton is at one of the premier pediatric hospitals in the country, and she's seeing a lot of pediatric HS. Now, one of the challenges is that you end up getting into the suffering Olympics when you talk about a disease state. But there are these measures of quality of life that are developing. And this is just one slide coming from Australia, but it tried to compare the impact of a disease like HS to other diseases. So when you talk about medicine, you can have a simple number. How many people live, how many people die? The more people are killed by the disease, the more society should focus on it. The challenge is that there's many diseases that don't kill you that make life miserable for years and years and years. And HS is one of them. So is asthma. So is heart disease. So is diabetes. So are amputations. And they compared all these diseases, and unfortunately, the quality of life of HS was actually as bad as somebody who had a lower limb amputation. It was more impactful than moderate to severe asthma. So when you're suffering through a horrible flare-up, you're not the only one suffering through this. And these quality of life measures, and there's lots of them, they are an innovation in research because it helps tell your story in a numerical context. It tells the story that Jasmine told so well in the narrative film format, in a database format that allows people to allocate resources. So that's one advance. Another advance that is happening is, when do we treat? Now, some advances are full of data that's reproducible, but this piece of work that came out of Europe a couple of years ago suggested that the earlier you treat HS, the more likely you're going to have a better response. Now, let me ask you this. How many of you have a family member with HS? Okay. So in our clinic, about a third of our patients report having a family member. In some of the work out of the University of Michigan recently, it suggested that up to 77% of people may have a genetic factor that is being passed on. So it seems to be that HS has a genetic component, and I vividly remember a patient, this grandmother came to Detroit in 2014, 2015 for surgery. She brought her granddaughter in. And she was probably in her late 70s, early 80s. And she's a black matriarch. Like, this is the mama you do not say no to. So she walks in, there's a certain level of dignity and respect we have for her. And she sits down, it's like, Dr. Hamzavi, you don't know who I am, I know who you are. You're gonna do surgery on my granddaughter. And I was like, oh, okay. I thought I was the HS expert, but okay. And she's like, I had HS in the 1950s and 60s. I suffered for years, and a surgeon at Henry Ford did my surgery, and I never had it again. My daughter decided to move to Atlanta, and I moved with her, and nobody wanted to do surgery on her, so I brought her back to Detroit. My granddaughter has HS, and that's why you're going to do surgery. And I did surgery on her. She's done well. She's a very successful PhD candidate now. But that grandmother knew more than most of the doctors. Now, if she could run our healthcare system, we wouldn't have had to do all these studies, but that window of opportunity is important. She recognized that if she waited too long, it would be very hard to manage it. So those of you who have family members with HS should recognize that you have to try to get this window going. The other thing that's in advancing is a lot of work led by Dr. Amit Garg in the Historic Initiative, along with Jocelyn Kirby and other members of the HS Foundation, is to find a way to measure what happens with HS. They're called patient-reported outcomes. So right now, the FDA uses a score called a HI score. Anybody know what a HI score is? A HI score is basically the number of nodules. When you have a treatment, do the number of nodules go down by a certain percentage? Let's say you had 10, and it went down to 2, the medication's helping. As long as you didn't form any new sinus tunnels. But how many of you have pain that is only related to the presence of nodules or sinus tunnels? How many of you have fatigue? How many of you have drainage? How many of you have to change your dressings? How many of you have to change your clothing? How many of you avoid intimacy, job opportunities, missed work because of this condition? How do you capture all that? And with good company feedback, because they've done this with other disease states, we're trying to develop these PROs, and the HS Foundation, along with Historic, is doing some work with C3 to try to develop better measures. Now, that may not seem like an advance to you, but if you develop a treatment, whether it's a diet, whether it's a pharmaceutical option, whether it's a surgery, a topical agent, you have to be able to address those. So these patient-reported outcomes, watch for those, because those will be another way of measuring what you are facing in a reproducible fashion. And again, we talked about the staging. One of the concepts I want to emphasize to everybody with today's knowledge, and it'll shift, is that you can only use medicines to stop new nodules. You can only use medicines to help with drainage and sinus tunnels. But if you don't do surgery once you have a sinus tunnel, you're not going to get the responses you're looking for. So if you're going to go to a center for HS, you have to have somebody who knows how to manage the medical side as well as the surgical side. And that's another advance. Now, we're going to talk a little bit about some advances, but I'm going to kind of leave this and go to this figure here, and I'm going to try to focus a little more time on this particular figure. So if you look at this image here, it tries to summarize what we're seeing with HS. The fulcrum, from what we know of today, of everything within HS is the immune system. But it's not obviously the only cause, but it is the process by which most of the inflammation occurs. And so think about when you cut your fingernail, or you have a cut after you are doing some plumbing your wife wants you to do, you hate doing plumbing, and you cut your finger and you get the swelling. Oh, I'm sorry, I shouldn't talk about myself. But then it swells up, okay? And then what happens after a couple of days? It turns red, and if it gets infected, pus starts coming out. Well, what happens with HS is that something is going on with that immune system. And that simple process, which all of us have gone through, where there's a little trauma and there's a pustular lesion, that's inflammation. Now then, many of us are familiar with acne. What happens with acne? There's no trauma. Suddenly you just get this pimple and it's full of pus. Well, there's inflammation with no trauma, no known infection. Now, this immune system is our powerful tool to protect us against infection. Well, this immune system is also controlled by lots of other places. And so one is the genetic factors. And there's been some very nice work coming out of Lynn Patrikova's lab, as well as Chris Syed's group in North Carolina and New York, that has been showing that they've identified some genetic factors. There's also work coming out of China, identifying genetic factors. And then at Henry Ford Hospital, we have a study called a Gene-Wide Association Survey that is looking at genetic factors that might explain some of the immune processes that are happening. Now, why is that important? Well, it comes back to this other section, which is the microbiome. When you have this immune system, and it's working, but maybe working a little too well, you're reacting to bacteria. Now, when I had less hair in my ears and more hair on my head, I was taught that all bacteria was bad. We were using these antibacterial soaps. We were using antibiotics for everything. And it was a binary. Bacteria present, bad. Bacteria gone, good. And like everything from the 80s, we probably had a few more excesses than we had to have. But there's more of a nuance to it, and that is there's good and bad bacteria. And the bacteria that we have in our gut, the bacteria that we have in our skin, they influence our immune system. And there's a relationship between our bacteria and our genetic factors and the immune system. And what happens is that our immune system is trained to live with each other. How many grew up in a household with a couple of siblings? Okay. So there's always an older sibling who tells everybody what to do. There's always a younger sibling who gets away with murder, and there's always a middle sibling who feels that they are underappreciated but is scheming to destroy the lives of the older and the younger sibling. We all know that story, right? Well, the relationship between the immune system and the genetic factors in HS is similar to that. There are times when siblings have a great relationship. They become each other's best friends. They support each other through a lot of stuff. And there's times when siblings don't get along. They might be in their 60s, 70s, 80s, but they have the nastiest fights. They don't talk to each other. They actually try to undermine each other. And if you view that as there's normally a stable relationship, but in HS there's a dysfunction in the relationship, that might start to kind of give us some clarity in what's going on. And then there are these lifestyle factors. One of the things with HS that we have to be very careful about is we have to be careful about talking about lifestyle. It is not our job to tell people what appropriate shape of the body is. It is not our job always to tell people that smoking always will improve your HS. Unless we have the evidence, we can't say that. But there is a role of adipose, fatty cells, which we all have. But adipose tissues become a hormonal component, and they seem to affect the immune system. And one of the advances we're finding out is that the adipose system seems to have an impact on this thing called the Th1, Th17 pathway. You're going to see a lot of new medications we're going to talk about. And the adipose tissue becomes a factor there. The rates of diabetes are much higher in HS patients. We believe that the rates of strokes and cardiovascular disease is also higher in HS patients. Why is that happening? There also seems to be a way in which HS patients process food that seems to be different, and that's why we're really working at dietary triggers. And I'll talk to you about a small study we did at Henry Ford that I hope will be replicated, that was funded by the HS Foundation, to show how diet can maybe be used. Mechanical stress. The genetic factors of our hair follicles create certain structures. Well, sometimes the hair follicle structures are not as strong as they should be. And as a result, due to mechanical stress, rubbing and friction, you tend to get a breakdown of these follicular cells. They plug up the hair follicle, and now you may get bacteria trapped there, and it'll trigger the immune system. So what this slide is trying to show you is that all of these factors relate back to the immune system, and the immune system is turned on. And you're going to see people who have metabolic issues are not an issue for them, but they have severe HS. They don't have diabetes. You're going to have people who have diabetes who have HS. You're going to see people who have HS in unusual locations. But the one thing you do find is that HS occurs in these areas where there's unique bacteria in underarms. It tends to occur in certain families at a higher rate, not in every case. And then there's differences based upon these factors. So when you have this disease that tends to occur in the same locations again and again and again, you can use these variables to try to explain why they're happening in certain locations. The microbiome of the underarm is different than the microbiome of the face. You don't see HS in the face very commonly. The mechanical stressors tend to occur in the axilla, and then you have the genetic factors and the lifestyle factors. So it's through the immune system that all these variables are happening, and that's one of the advances that's kind of happened the past couple of years. I want to go through that before I show you this slide. Even an advanced dermatology resident who has a degree and a PhD in immunology has a hard time with this slide. The point of this slide is that it's very complicated on what's going on with HS. But I want to kind of focus on two terms, Th1 and Th17. Those pathways seem to be the big drivers of immunology in the first phases of HS. So this hair follicle over here is a big pus bump. It's a nodule. When you have multiple hair follicles inflamed, you have that nodule. That golf ball sized lesion that's so painful you just want it to burst. And sometimes we help you by decompressing those. But that's the first phase of HS, and it seems to involve this Th1, Th17 axis. Some people respond to this medications called TNF-alpha inhibitors. Some people respond to these medications which block IL-17. And IL-17 has a bunch of cousins, IL-17AA, AF, FF. But all these medications that are using IL-17 are related. So in the earlier phases, it seems that those are the key drivers, but these medications don't work well in everybody. And there's a medication that uses a pathway called IL-23. It is probably the best medication you can find, maybe with some argument, but a lot of people feel it's the best medication for the clearance of skin and psoriasis. And we had a lot of hope that those medications would help. But when we tried those medications, they didn't help. And then the medications that seemed to be working seemed to work on the IL-17 pathways or variations of those. The problem, though, is that they don't work in everybody. And in every study, you're getting a 40, 50, 60% improvement, but no medication has cleared anybody completely when they block these pathways. So that's where our basic scientists are starting to look at these areas. So when you form a sinus tunnel, you don't see pus cells or neutrophils. You don't see as many T cells. You see these cells called B cells. So B cells are kind of like the person who kind of encourages everybody, like the Aunt Bessie, who's always positive. Honey, that's not a bad outfit. It just doesn't match your color. You know, you're not a bad basketball player. You just look really good on the bench. Like B cells, they just tag things, they mark things, but everybody loves Aunt Bessie, and if Aunt Bessie's been in a place, she kind of stimulates and kind of keeps everybody happy. And everybody knows Aunt Bessie. So B cells don't do a lot, but they identify targets. B cells are very, very active or present in sinus tunnels. And one of the advances happening is that we seem to need to target these T cells, which are affected by the Th1, Th17 axis, and B cells. And one of the advances coming up is how do we use two medications in one to target both those areas? But the other advance is how do we figure out what stage an individual with HS is at so that we can come up with the right medication for them? So we have these advances. They don't work in everybody, but with appropriate questions, blood tests, looking at examine the individual with HS, we can use the appropriate medications, and we can work with our pharmacologic partners as well as with basic scientists to find better targets. Because even with the best studies and we've had some great studies recently, we have not cleared everybody, but this B cell, T cell explanation might be helpful. So that's another advance that's happening. This is our basic science team. I'm not going to go into that too much because, there's other things to talk about. Other things that have come up with HS recently is, unfortunately with HS, there are a lot of comorbidities. One of the first things that we noticed in our clinic, and Angie Miller and Sandra Giebald, who helped start Hope for HS, which has many chapters, HS Connect, HS Warriors, all of those patient support groups will talk about the need for a community, but also the impact of HS on the quality of life. And when you have quality of life issues, you have impacts also potentially on mental health. Now, when we measure mental health in HS patients, unfortunately, it's much more challenged than the rest of the population. So the rates of depression, anxiety, and suicidality are higher. The rates of addiction are higher. That doesn't mean that every patient is going to have it, but we are getting much better at tracking that and working with people such as Aaron Martinez. Brent and his team at the HS Foundation have invited people who have social work or mental health or psychiatric benefits, and all of us are getting trained better in that. But some of the pain that we manage with HS, we have to use these pathways, but we're recognizing it, but it's real. Metabolic syndromes, we talked about those, diabetes, cardiovascular disease are being discovered. Spondyloarthritis, we are identifying a lot of individuals with HS who tend to have this low back pain. And the low back pain doesn't always have the blood test that tell you why it's happening, but when you do an imaging assay with a device, an MRI, you can find inflammation. It's also helping us find better treatments for those individuals who have skin pain, skin drainage, and joint pain. And then the recognition that inflammatory bowel disease is present, but we're learning how to use medications to treat both. Inflammatory bowel disease is inflammation of the gut in which you get a lot of bloody diarrhea, a lot of abdominal pain. It occurs in about 0.5% in the United States, but it's about 3% of our HS patients. Now, when I say something is more common, it doesn't mean that everybody with HS is going to get it. It just means it's more likely. And lastly, polycystic ovary syndrome and sexual dysfunction. Periods are missed, inability to be intimate. Those are all issues that we're noticing with HS. And we're getting better. We're developing the capacity to document that in a more effective fashion. Another advance that's been happening the past couple of years has been advances in guidelines. And Chris Syed and Ali Khan and that young man over there from the great state of North Carolina, Tar Heel, where they actually win basketball games. Not recently, but they used to. Mr. Hazlitt has done a lot of work organizing our HS experts. Dr. Cotton is also serving on some of those committees and trying to say, well, you tell me what the best treatments are. Let's publish those. And if you go to the HS Foundation, you can find these guidelines, and this is the most recent one. There's another set coming up, and it took a lot of effort, and Chris Syed, he smiles through all of the hard work at University of North Carolina, an incredible young man, done great work. And the evidence guidelines, it's evidence, but it came down to this picture. And there's lots of things on here, because at the end of the day, we can make lives of HS patients much better, but we can't cure the disease today. But we can make life worth living and functioning. But in order to do that, the guidelines suggest that you have to reduce the number of nodules, you have to reduce pain and drainage, and then if you get stuck, you do surgery for these areas. And this listed all the different treatment options. And these guidelines are on the website. If you ever have a doctor who doesn't know what to do with HS, refer them to the guidelines on the website. And that was the old website. And then, I just want to kind of get into some of the other advances. Laser hair removal is another advance that's happened the past couple of years. The first studies on laser hair removal were done here at Henry Ford. We've identified a laser called a YAG laser, but it tends to work in people who have the follicular, the nodular HS, early stage 1, in which antibiotics and washes and other things don't work. And that's been advanced. And then, let's go to the next slide. Antibiotics, they're getting better at using antibiotics based upon French work. You have to use antibiotics for a longer period than we thought, and then you have to use a different set of antibiotics than we thought before. We're also understanding the limitations of antibiotics because we believe that antibiotics reduce certain bacteria that turn on the immune system. But the problem is the relationship between the immune system, the hair follicle, and your bacteria. When you use antibiotics, you reduce bacteria, but they come right back. And that's one of the challenges of HS. But if you use the antibiotic with the understanding of the immune system to give the immune system a little bit of a rest, you're taking away the target of inflammation. then sometimes the inflammatory cycle can reset. Just like when you have a donut, the kids are fighting over the donut, they want to fight over the donut, you take away the donut for a while, everybody suffers, and then they reset. Most of the time. Okay, never, but we tell everybody that. And then I wanted to kind of jump into surgery and some of the advances that have been happening. So Dr. Rambatla from our department did some work with this, along with other centers. But de-roofing is a simple technique, and I hope this isn't too graphic, but we do a lot of ultrasound in our department to identify where the sinus tunnels are. And I think one of the advances that our group and other groups have identified is sinus tunnels are very superficial. They're kind of like balloons. When you have a sinus tunnel and it's really inflamed, the balloon expands and it presses down on all your nerve fibers and causes tremendous pain. But when you're trying to remove those tunnels, you don't need to go down to the deep levels of the skin. You go right at the junction of the fat, right here, and the dermis, right here, and you can usually remove those. And this is what this ultrasound is showing, and this is an example of a sinus tunnel. The fatty tissue is yellow over here, the sinus tunnel is right here, and you can pass a probe right through that. So when people are doing surgery, they have a better idea where to excise, but also, if we can find this tunnel, we can open it up, like we are with this technique. We can make a small incision, not take out any tissue, scrape it out, and it heals faster. And that gives people about a 77% improvement rate. We've also been working on definitions so we can do better studies of surgery, and Chris Syed, with his Patient Way, along with Falk Bachara and many other surgeons throughout the country, have worked very hard to define standards so that we can look at surgical interventions and see which ones work and how well they work. When we give you these numbers, they have to mean something. But if you have kids and you've made 3 hamburgers and everybody has a different definition of how much is enough ketchup, you have to standardize it. It's a packet of ketchup. Now, if you allow people to decide how much ketchup is appropriate, they're going to take 14 packets. We're going to fill it up. So we've defined what is persistence, what's progression, and now we can hopefully develop better comparisons. And that's taken us a couple of years, and this paper will be published in the near future. Intralesional steroids. Anybody familiar with intralesional steroids? So when you have a bad flare-up, a lot of times you have to go in and get a treatment, and there was controversy whether or not that even worked. And Chris Syed published a paper saying it didn't work. Another paper came out of Denmark saying it does work. Another subsequent paper suggesting that we have a better idea of what the dose is and how well it works. They do work, but you often have to use higher doses than what most dermatologists are comfortable with. But that's an acute treatment that we can use for acute pain. That's another advance. And then I want to kind of jump through a couple of slides here and get into some of the new advances in the pharmaceutical options. And this is a de-roofing video. If you're ever interested, we can talk about it. This is a laser hair removal device if you're interested in knowing what that looks like. HS does work, and this is the type of patient that laser seems to work in. Females tend to have a lot of follicular diseases, tends to respond to laser hair removal well. And even in lighter skin and darker skin individuals, you can have a response. And I apologize for the graphic nature of these images. And I want to kind of quickly go to the, so if you can bear with me for a second, I'm going to jump into beyond the surgical procedures is the keloid formation. So one of the questions that we've often been asked is, we have a lot of Black American patients, the rates of keloid formation. Anybody know what a keloid is? It's a very thick scar that is much bigger than the original incision. And a lot of people don't want to have surgery, and people were told you can't do surgery in Black Americans with HS because they might form a keloid, because the HS lesions look like keloids. It's not the case. We did 129 of these. We had no keloids. Now, if you have a keloid in your ear or after a C-section outside of HS, then that's a different story. But Black Americans, people of color, are not at higher risk, so you should be able to do HS surgery. And that was a recent advance. One of the advances we're also trying to understand is that we're all different, and I'm going to quickly go through this, but one of the studies done at Henry Ford on 14,000 patients identified renal disease. Renal disease is more common in Black Americans than it is in white Americans. And then prior authorization tools, one of the advances that we have to make is we have to get these medications accessible. I think this is one of the advances that have really helped my clinic. You know, the HS Foundation, you can have your doctor fill out a form to get medications. If you say that's rejected, say, well, did you fill out a form using one of these letters? And they'll be so happy you found it for them. And then upcoming treatments. So I wanted to kind of quickly talk about these targets. So we're going to talk about the IL-17 medications. We're going to talk about these medications that target B cells. We're going to talk about these new medications that are called JAK inhibitors. JAK inhibitors target the immune cycle. So if you think about a lock and key, that's kind of a biologic, an antibody. What happens inside the house exactly at the point of trauma in a criminal activity, well, a JAK inhibitor goes deeper into the room and it stops the actual event, much more targeted, and it acts inside the cells. And those are also coming up. And then lastly, we have these new targets which are going to target both the plasma cells and the T cells coming up, and they're coming up in studies. So what this graph, which has a lot of different medications listed, is just trying to show you which of these medications are working. So far the JAK inhibitors are showing a lot of promise, and then the IL-23 inhibitors did not work. So then we advanced and we started looking at other JAK inhibitors, and they made it through the phase 2 trials, and now some of them are going to phase 3. They're oral tablets. They increase the risk of blood clots. They may increase the risk of cancers, but at a very, very low rate, but they also may offer better options and better results. Now, when you look at the difference between the placebo, the people who never got the medication, the active drug, this is the difference. The problem with HS studies is that even the people who don't get drug improve or get worse. And so you have to look at the difference. And that difference is greatest so far with some of these upcoming JAK inhibitors as well as some of the IL-17 inhibitors. Now, these are the big mama studies of HS. These ones are phase 3 trials which have had dramatic improvements. There's a medication called secukinumab which has made it through into full approval now. It's an IL-17 inhibitor. IL-17 ANF inhibitor is called bimekizumab, is likely going to come up for approval. And then this compares that to adalimumab, which is a brand name Humira, which is the granddaddy of biologics. In these studies, it seems to be that the IL-17 inhibitors seem to work as well as the TNF-alpha inhibitors, but it seems to be based upon the population that you have. And reports that we're getting from the clinics is that sometimes people are doing very, very well with secukinumab, sometimes they're actually getting worse. Bimekizumab is not available in the United States yet. It's available in Europe for HS, but in the studies, it seemed to do better than adalimumab. So these IL-17s are coming up. There's one already available in the marketplace. There's a lot of success coming up with those. And then, thank you for that. And then other phase 3 trials are being advanced. And then the other advance that's been happening recently is these drug survival curves. We don't have enough money in our system to do these very expensive studies on every patient. So what we've been doing is looking at drug survival. If I give you a medication, how long are you taking it for? And our question at Henry Ford, as well as these European studies, was at 1 year, if we start you on a medication, you're still taking it. And there's an infusion called infliximab, which seems to be the best agent so far. In our practice here in Detroit, 70% of our patients are still on infliximab at 1 year. About 30% for adalimumab. We don't have that data for secukinumab. But now we know the dosing is 10 milligrams per kilogram every 4 weeks for infliximab. So if everything's failing, consider going to infliximab. And then there's still 30% that don't respond, at least in our centers and other centers. But that seems to be the drug that's worked the best. So lastly, I want to quickly speak about diet. I have maybe 2 minutes left. And diet seems to have a role. We worked with the foundation to design a study to assess diet using inflammatory markers. And Jillian Drenka, who's a nutritionist in the area, helped us with it. And we were able to show a difference. Very small numbers of patients, but half the patients who did the study dropped out. But if they could do the study, they had dramatic improvements in their nodules. But we need to do these studies in much larger scale, and we'll need the support of the foundation and all of you to participate in these studies. We need a lot more funding for that. So I wanted to kind of provide you references. I also want to encourage you to come to SHSA meetings as well as the HS Summit. You can go to the HS Foundation. I hope this very long talk was helpful to you, and if you have any questions, I'm happy to take those. Please, in the back.
Oh, I gotcha. Thank you so much for a very informative talk. My question is, well, I'll first start with a statement, and that is we all know that correlation is not causation. And you did mention that there seems to be some correlation with, you didn't say directly BMI, but obesity with HS symptoms. We don't know the mechanism of that, I'm sure. But I'm wondering if anyone has thought perhaps about the use of these drugs such as Ozempic and Wegovy to help folks reduce their body mass for HS.
So there's studies going on, lots of interest in that. Colleen and I are on a physician group that's talking about that quite a bit. There were studies done with bariatric surgery, looking at HS before and after. And in the small case series, they seem to improve. We did a similar study within our patient population, and only half the patients improved with bariatric surgery, and the HS flared in the redundant skin. So I think it's an open conversation. It's got a role. Correlation is not causation, but we have to kind of look at that. But I think data will help us understand whether or not the GLP-1 agonists, such as the ones you mentioned, are helpful. But it is a role of research right now. I should have mentioned that, but there are not any large-scale studies. Colleen, I think there's no RCTs going on with that. So anybody from industry doing, please.
Oh, wait, what were you guys saying?
Oh, please, go ahead.
Hi, so I'm currently in remission. I've had surgery, but I've also changed my diet. I don't want to be vegan anymore. And I'm just afraid to like reintroduce certain things that I've removed from my diet because I don't know if I'm going to, come out of remission. So like, what's like the safest thing to do? Like, I just don't want to flare again, but I feel like I'm lacking. I feel like I'm always fatigued and tired, hard to get up, move around just because I'm not eating meat. I also don't eat dairy and gluten, so I'm just kind of lost on what I should be doing for my diet.
Thank you for that question. I was hoping somebody would ask me that because I can't put the data up, so now I'm going to talk as a clinician. So clinicians are kind of like, we're like a recipe maker. We have to take data, but we don't always have data for many diseases. So the reality is what I'll tell you in my clinic, because you gave me that pathway. So this comes up all the time. So first off, eating food and not eating food are both treatments. So you can't just say that I'm going to avoid this and I'm going to make my HS better, or I'm going to add this and make my HS better. You might make the HS better or worse. We don't totally know. We have methods, but we don't totally know. We also don't know if it makes something else worse. So the methodology that we laid out in this study, that Brent hopefully will help to find the money for, and Colleen can do the study and we'll give you the methodology. But in this methodology, what we did was we used a thing called the LEAP system. And we did this blood test called a flow cytometry, and we identified inflammatory foods. Then we paired you with a nutritionist who was looking at your overall diet to make sure you have enough protein, zinc, copper, which are critical elements for wound healing and for HS. And there's a few studies suggesting that zinc might be helpful. And in that context, they would introduce food that was on the low inflammatory side. So let's say they did the blood test and they found corn and soy are high inflammatory. You find everything without corn and soy, but you also watch your overall protein intake, because I can assure you your protein intake is probably not enough for you. The reason why you're having so much fatigue is a factor. And so you have to have a physician, a clinician with you. You also really need a dietitian. And Jillian Drenka, I have no conflict of interest. She's wonderful in our area in Michigan. I'm hoping that the HS Foundation will help identify dietitians and nutritionists throughout the country. But that's the way you do it. With the LEAP system, you do it every 2 to 3 months. You can measure your nodule counts with your physicians or yourself, and then you can hopefully introduce foods. And you're going to have foods that will flare you. That's okay. But the flare may happen anyway. So what we try to do is we try to identify a baseline of how many flares you have per month. Then we look at that. And then if you have 2 or 3 flares and you have 2 or 3 flares, right when you have the flare, you're going to think, oh, it's the food I just ate. It's not, because you're having the same flare you have every month because you mapped it out before. Now you go back to your nutrition and say, well, what did I do differently? Well, you just added this new food recently. Okay, then we go back. And they use a combination of technology, food diaries, and Jillian just did a whole session with our Hope for HS panel in which she cooked for patients with HS and showed them how to make food, also how to add and remove. But food is a drug, and you have to kind of balance it all out. And I hope that you have a good journey with that. Finley, how are you?
I'm good, how are you?
Thank you for being here.
I just wanted to mention when you were talking about tracking that for anybody who doesn't know, the Papaya app is a great place to track. It's not available yet on Android, should be this summer, but it was designed with HS patient and patient advocacy groups, with 2 HS specialists as well. But it's a great place to track if food you're introducing, your flares, drainage, odor, everything on there. It's kind of a one-stop shop, so it may be a good place when you're talking about reintroducing foods to track all of that.
Yeah, I want to get that information on that app. I also make a plug for HydroWare, which was also developed by an HS patient to help with wounds and drainage. But again, our patient community is actually part of our innovation community too. So keep bringing those things up. Thank you for that. So how about we go with the young lady here, and then we'll go to the, go ahead, please. Yep, and then we'll go back to the person behind you.
Okay, so my question revolves around the staging system.
Okay.
Because you have stage 1, stage 2, stage 3. I went to a stage 3, got surgery, medical attention, and I've done so much better. So my question is, when I'm online talking to my followers, am I still a stage 3, or am I technically a stage 1 now? Because I was a stage 3, but
Yep,
now...
so you're stage 1 now, because once you remove the sinus tunnels, that skin has all the fibrosis, all the plasma cells, all those sinus tunnels gone, and now that scar tissue doesn't have that inflammation, so you're stage 1 now.
Okay, go me.
Or stage 0, actually, because you have no nodules.
Dermatologists, thank you.
And it happens. Great story. If you could pass it back to the person behind you there, thank you.
Okay, so mine actually isn't a question for you. It's the go back to your question. So just speaking for myself, right? So I have PCOS, diabetes, and HS. And so they are all linked with like being insulin resistant. And I started taking metformin and Ozempic for my diabetes, and it helped. I didn't lose a lot of weight, but it has helped me with my HS flares, right? So like I'm not getting them as much anymore. And when I do get them, they're not nearly as painful. And it's helped me with the PCOS as well. So controlling my insulin has helped me with all 3 of them. So
Great. And that's stories that become research. I have to wrap it up, but I would love to take some questions, maybe individually, if that's okay. Is that okay? Or do you want me to wrap, because you had a sign saying wrap it up? Okay, so. But I'll keep going if you let me. But can I take a couple more questions, or? Yep. Okay, how about we go with the person back there, and then we'll come forward. We'll take 2 more questions, and then I'll definitely catch up with everybody afterwards.
Thank you so much.
Thank you for being here.
This is kind of a question/statement. I was just wondering if you guys have looked into using things like high-frequency wands and red light therapy for helping with your HS. I've talked with my dermatologist before about it, and they were clueless, but I have seen tremendous results. I had a flare-up on my face that high-frequency worked with, and then red light therapy, I have been in remission on my face for 1.5 years now. So I'm just wondering if you guys have added that to your research.
So this is the home of the Henry Lim Photomedicine Center. It's one of the most active centers in the world for photomedicine. So we have a full-time physicist. We describe this thing called the visible light effect, which causes pigmentation and erythema. Did a lot of testing for sunscreens. So we've been looking at red light therapy for wound healing. There is very few randomized controlled trials. And then the inclusion-exclusion criteria is not consistent. For acne, facial lesions, there is evidence suggesting that red light and blue light help. Now with HS, the studies are on two components. One is for wound healing, probably helps. One is to prevent flares or treat flares. No data on that. So I think it's something that, again, we got to bring it up. How do we do these studies? Because they're hard to fund, they're hard to organize. But yes, I think there might be a role, but it's hard to say yes right now.
Thank you.
Yep. And how about we go there, and then we'll come back to you. And that'll be the last two. So please, with the glittery blouse there.
Hello. So I have Crohn's, HS, diabetes, and then I have a lot of sinus tracts and tunnels. This is like a hypothetical thing, but if I get those tracts removed or the surgery, I've had a couple of them done, just because I have all those comorbidities with those tracts, would I always have them? I mean, I know that's a big always thing, but those things, diseases probably will always be there.
I never, as an HS surgeon, I never shy away from those cases. If your inflammatory bowel disease is well controlled, if your hemoglobin A1C is well controlled, you'll do fine. HS wounds heal faster than most wounds, and if I can give a chance to give you a lesion on your body or a part of your body that's early stage 0, I will work with you to do it. And if hypothetically you were in a clinic with any HS surgeon, as long as you're managing the medical side, we can do it. Hypothetically.
Right. Thank you.
Last question from the person in the blue jacket, and then we'll finish up. Yeah, I'm sorry. Mm-hmm. You can. So as people enter perimenopausal, postmenopausal, the hormonal axis goes down. Unfortunately, about 16% or so of patients will continue to have HS, but a majority, the HS will resolve. Yeah. Right. Yep. Yep. And so yes, you do. But it's also, if you could just make sure that your family, so make sure your family knows about it, because a lot of people didn't talk about it. So, well, thank you for having me here today. It was so nice to see all of you.